welcome to the FlightBridgeED Podcast series. Hey folks, Eric with you with FlightBridgeED. Today we're going to do another case study, a case presentation regarding a 6-year-old male with an asthma exacerbation. I've also received quite a few comments and questions over the last couple months regarding the management of obstructive lung patients, specifically asthma. So when I came across this case study, I thought it would be fitting to present this. This is a real flight, a real patient presentation. I think that we've had great listener support and a lot of downloads, thousands of downloads based on these case studies. So I think we all learn the best in that way. If we can look at a case study, we can apply that, think about it, and then we can apply the treatment modalities based on that presentation. So I'm going to go through the presentation. I'm going to kind of talk about different aspects physiology-wise, some things we need to look at. We're going to go through interventions, pharmacological interventions, and how to kind of approach a pediatric asthma patient. I think the big thing that we have to realize is that the approach for asthma treatment in general has changed, and our mindset has changed over the last few years from maybe being aggressive pharmacologically, but at some point, we always would intubate these patients. If they just didn't get better, we would intubate them. And now kind of the mindset is you wait to the very, very last minute to do so. You exhaust every means, and you almost have to let them kind of just stay in that state for quite a while before you decide to do that. And for some, that's going to be hard. It's going to be hard to watch somebody suffer in that way, where they're air starved, where they're panicked, they've got anxiety, and they just look like they're about to die. We have to allow them to work through these things, because we know that putting them on the ventilator is going to be, although in some people's minds the most appropriate treatment, we also know that causes associated problems and can increase mortality, and a lot of times taking your patients off of a ventilator that have the disease process of obstructive lung disease is quite difficult. So the new mindset is to do everything and anything possible to not have to intubate these patients. As we go through this, we're going to identify all these treatment modalities, and at the very end, we're going to look at ventilator strategies real briefly, just in case you do see this patient on a ventilator, you choose to intubate them based on their presentation. We have to understand how to treat them on the ventilator, because that can be kind of challenging. All right, so let's start. We have a 6-year-old male patient that's admitted into a local ED. You as a flight team are called to transport this patient to a level 1 pediatric facility that can handle this disease process a little bit more aggressively. The patient had an acute onset of symptoms after playing in the woods with his brothers and sisters, and has a history of asthma of about 2 years. At this point, you arrive on scene, you identify that the patient has been given 3 albuterol treatments and 2 Atrovent treatments by nebulizer, and they did give the patient some PO steroids. The history of asthma since 4 years old, has had 6 previous admitting diagnoses to the PICU, but he's never had to be intubated. So that's kind of a good thing to know and to ask. Current vital signs, has a heart rate of 147, so we know that's pretty tachycardic for this patient for this age. Respiratory rate of 30, again, that's elevated. We would want or expect the patient to be about 18 to 20, most likely. O2 sat of 85%, not terrible, but definitely hypoxic, and that is on room air. BP can't be obtained at this point, but just for purposes of the lecture, let's remember the math or the criteria for identifying a blood pressure with a pediatric patient. It's going to be 70 plus 2 times the age. So this patient is 6 years old. We would identify his systolic blood pressure at 6 times 2 is 12, plus 70 is 82 systolic. That's where we would like to see his systolic blood pressure. When we talk about pediatric patients, for me, that's the last thing I'm really worried about is the blood pressure. I'm going to look at the heart rate a little bit more closely than the blood pressure, and that's going to be a secondary thing, a secondary tool that I may use if need to be or if I have time to do so. But I'm not going to get real worried about not getting a blood pressure. The next thing we want to look at is this patient febrile? Is this possibly an infectious process? Is it some type of other presentation? Is this a new onset pneumonia or something like that? And at this point, the patient is afebrile. Now, obviously, with a new onset infectious process, you may not always see a fever immediately. So we would want to get some lab work, look at his white blood cells, his leukocytes, his bands, and things like that to identify if he possibly has some type of infectious process. The next thing we want to look at is his lungs, and we can look at his lungs in 3 different ways. The first thing we do is whenever we walk up to a patient, obviously we want to assess his mentation. We want to assess if it bothers him for us to touch him, for us to ask him questions, to be around. And a 6-year-old, they're kind of in that state where, they're a little bit trusting, but they could be a little bit modest, and they may not want you around them. So, how does he react to you? You attempt to ask questions, and you note that he answers in one-word sentences. So that's probably not a good sign. You also note that he's got marked intercostal and suprasternal retractions on your inspiratory and expiratory phase during his respirations. You listen to lung sounds, so that's the second thing we do. We're always going to listen to lung sounds, and you note that he's got decreased breath sounds on inspiration, and he's got audible wheezes on an expiratory phase. We wouldn't want to see a silent chest in this patient. If we saw a silent chest, that's going to be a very ominous thing. And so having lung sounds, having even though decreased lung sounds and wheezes on expiration, that's better than the alternative. The next thing we want to look at is his blood gas. They did get a blood gas about 30 minutes ago. His pH is currently 7.32. He's got a PaCO2 of 58 and a PaO2 of 50. So let's kind of identify this. As the pH is 7.32, that's going to be an uncompensated acidosis, all right, of some sort. His PaCO2 is 58, so that should be telling you he's got too much acid. He's retaining CO2, and that's going to be a respiratory component, so that's higher than it should be. Our range is 35 to 45 with a 40 being perfect. The next thing we want to look at is we want to look at the next thing we want to look at is his PaO2, and his PaO2 is 50. And so we know that a normal PaO2 is 80 to 100. He's at 50, so that's telling you there's some level of hypoxemia. We haven't identified why, and we'll get to that here in a few minutes, but there is a level of hypoxemia. So basically, based on his blood gas, he has an uncompensated respiratory acidosis with an associated hypoxemia of unknown etiology. So we need to identify the hypoxemia very quickly. And the thing to remember on asthma patients, COPD patients, obstructive lung patients in general, is that they always most often suffer from ventilatory failure first. That causes a decrease in chest wall compliance, air trapping, and auto PEEP, which limits our tidal volume. If we have limited tidal volume, that means we have limited minute ventilation, and we don't have enough volume or minute ventilation to diffuse through the alveolar membrane, to be picked up by the plasma, to be picked up by the hemoglobin, and so you become hypoxic just based on the low minute ventilation. So if we fix the bronchial constriction, if we fix the chest wall compliance, and we start allowing them to blow off the CO2, just by doing that, you're going to start increasing tidal volume. That's called functional residual capacity will improve, and his oxygenation status will improve accordingly. So for me, I'm not going to be too worried about the oxygenation status in this patient. I'm going to be more worried about the CO2 retention and the air trapping and the auto PEEP. And so we're going to talk about that in general here in a second. But what do we do to define respiratory failure? This patient is a classic respiratory failure patient. And to have true respiratory failure, you have to have a hypoxemia. So you have to have a PaO2 less than 60. Remember, 80 to 100 is normal. And then you have to have a hypercapnia or a CO2 problem where the PaCO2 is greater than 50. And so this patient also had a PaCO2 of 58. So he classified easily as a respiratory failure. When you have these both, that's called a mixed disturbance or a mixed respiratory failure, and he has both of those categories. So why do you think this patient is hypercapnic? What causes an asthma patient with this disease process to become hypercapnic? Well, remember, they start having a response based on bronchial constriction. This bronchial constriction causes them to become anxious. They start getting anxiety. They start increasing their respiratory rate. When they start doing that, you have less of a time to blow off CO2 or to exhale. As he starts taking a breath in, that's during the exhalation phase. So you start stacking breaths on top of breaths. It starts enlarging that chest wall cavity. It starts decreasing the ability to blow off more CO2 because your alveoli become very engorged. That's the auto PEEP aspect. And it starts compounding on itself. So we need to start looking at ways to help him blow off CO2. Again, and then the second thing is, why is he hypoxic? And we identified that. It's most likely because of the chest wall compliance is impeding his ability to take a good vital capacity breath. So if we fix that issue, the oxygenation aspect will take care of itself. So what happens with asthma? I'm not going to get into a long pathophysiology rant on asthma, but essentially asthma is a response of a white blood cell called a leukocyte. That leukocyte puts out an inflammatory mediator called leukotrienes. Leukotrienes, again, start this inflammatory response, starts building up mucus in those airways. It starts causing constriction. It starts breaking down and attacking those epithelial tissues in the lungs, causing this massive inflammatory cascade. So it's our body that's attacking itself in this instance, and it's stimulated or started by some type of antigen, some type of dust particle, a dog, cat fur, anything like that. Any source mediator that could trigger this causes that problem. And everybody that has asthma has different triggering aspects. So when we treat this patient, we need to do a few things. The first thing I said is, remember, his respiratory rate is in the 30s now. He's not able to exhale appropriately. So we have to think about how are we going to treat this patient in a way that is going to optimize bronchial dilatation, that's going to allow him to rest a little bit, but we don't want to intubate him. We want to keep him off the ventilator. So that's something we got to think about. The next thing we want to think about is, how are we going to treat this patient and rule out other causes? And so we talked earlier about lung aspects and things like that. Well, we would want to get a chest x-ray, and we wouldn't want to hold off treatment and stuff like that, but get a chest x-ray, identify very quickly. You identify based on the labs, on looking at the white blood cells and leukocytes and the bands, if there's an infectious process. Look at the chest x-ray, rule out pneumonia, and most likely in an asthma patient, what you're going to see is you're going to have a hyperinflated chest, you're going to have a very flattened diaphragm, your lung markings are going to go all the way up, almost looks like it goes up into the neck area under the clavicles, so very hyperinflated lungs. That's probably because of their air trapping, their auto PEEP, and they just have all this stored air. So that's going to give you kind of a guideline of treatment. Right, I'm a big component on never shooting in the dark. Obviously, in some instances, you need to treat things aggressively, prophylactically. And an example would be in a new onset infectious process, you would probably give broad spectrum antibiotics to, before you're going to get cultures, to try to hit everything you can. So, an example would be given Rocephin, given vancomycin and gentamicin to kind of encompass everything in maybe a pediatric patient that is possibly septic. So that's kind of the exclusion in that situation. But I'm a big component on finding the source, getting the patient out of the source, and then starting down a road to know where you're going to end up. So we know that this patient is probably suffering from his normal chronic asthma. He's having an exacerbation. So how are we going to treat this patient? Well, the first thing that I would do for this patient, and I think we miss this, we forget about this, is treat this similar to anaphylaxis. Anaphylaxis is going to be a vasogenic shock. So giving pediatric patient some fluid volume, giving him 20 cc boluses is going to be a good thing. The second thing is treat this with epinephrine. Give him sub-Q epinephrine 1 to 1,000. You can go all the way up to 0.5 milligrams per kilogram. Give him epinephrine 1 to 1,000. You can go all the way up to 0.3 to 0.5 milligrams. Give it IM, and you can give 3 doses. If you choose to do that, that's great. You can also go breathing, which is also a beta-2 agonist, and you can give kind of the same range up to 0.5 milligrams per kilogram. The next thing you can do is to give breathing or terbutaline, and the dose for that is 0.01 milligrams per kilogram. Sub-Q, you can go up to 0.5 milligrams as your max dose. You can give up to 3 doses in that situation. So again, start aggressive. Try to get a hold of this disease process right away and cause some profound effects from those beta-2 agonists. The next thing we got to think about is starting with giving oxygen, right? And we always know we're going to give a non-rebreather 15 liters per minute starting out, but we need to start getting some type of nebulizer treatment started immediately on this patient. And we can go with multiple medications. And the first most standard one is going to be albuterol. Give albuterol. It's a beta-2 agonist as well. It's got some beta-1 runoff, so you're going to have some heart rate effects with that. We already saw that this patient was a little bit tachycardic, 147, 150 area, and so just be cautious. Obviously, a 6-year-old male can handle a heart rate being that high a little bit better than a 50 or 60-year-old male. But you could also go with Xopenex. Xopenex is a very prominent beta-2 agonist. It doesn't have really any beta-1 runoff, so it's very good for those patients that already are tachycardic. The next thing you would do, and you would do the same dosing regimen for your albuterol, 2.5 milligrams in a neb. You could mix it with some saline and nebulize that in with about 8 liters per minute. And what I like to do for these patients is get a non-rebreather, take the mask off, put the reservoir canister in the hole, and then put the mask on, and that way they don't have to hold it. And I like to do that for my adult population as well. It just saves me having to constantly tell them to hold on to it, and it allows them to not have to worry about holding on to it. Remember, the next medication we would consider would be Atrovent. And Atrovent, remember, is an anticholinergic medication. It's a parasympatholytic, and so it's excellent for our pediatric population as a drying agent and for this type of disease process. All right. At this point, we've started with our epi. We've been aggressive. We've considered breathing. You could go one or the other. We've started our oxygenation. We've started our beta-2 agonist as far as our albuterol. We've considered Xopenex. We've went with Atrovent. And now we need to think about kind of throwing something in here that's something that we primarily didn't do. And our first line thing, oxygenation-wise for our pediatric patients, is going to be considering using BiPAP. And so BiPAP in these types of patients are huge. We need to understand that BiPAP is going to cause an increased functional residual capacity. It's going to improve holding open those alveoli for better oxygenation and diffusion. Because remember, when you're talking about an asthma patient, you're having basically dead space ventilation. The dead space ventilation is because of the narrowed airways and vessels. Everything is constricted off. So you have no way of transporting those oxygen molecules or those CO2 molecules through the blood and through the alveolar membrane sufficiently because of dead space ventilation. And we know primarily dead space ventilation is usually because of a cardiac output problem or in severe cases a pulmonary embolus. But in these patients, it's all because of high airway pressures and bronchial constriction. So we need to start thinking about how we're going to decrease this narrowed airways. We started the pharmacological intervention with our beta-2 agonists and medications like that, and start giving patients BiPAP. Before we give BiPAP, it would be good to give them some type of sedative medication that would just calm them down a little bit prior to applying a BiPAP mask. Right, that could cause them some more anxiety. It could increase their respiratory rate a little bit. So give them a medication that's going to give them some sedative effects. Obviously, we don't want to knock out the respiratory drive, but just small aliquots of this medication. And that medication is ketamine. And ketamine is excellent in the pediatric population for an asthma exacerbation because it has very profound bronchodilatory effects. It also has very stable hemodynamic effects. It's excellent on pain. It has some analgesia on top of it. And so it'll calm these patients down. It'll allow their respiratory rate to come down. That'll optimize their exhalation phase. And then now we're applying BiPAP. And so the big thing with BiPAP that we have to remember versus CPAP is CPAP, you're giving an inspiratory pressure throughout the whole face, and that's your IPAP. And it doesn't allow them to exhale over a lower pressure. So I would recommend just going straight to BiPAP. And remember with BiPAP is you have this set on IPAP of, let's say, 10, and you have an EPAP, let's say, of 2. All right? And the way to look at BiPAP based on an oxygenation failure or a ventilation failure is a little bit different. Your IPAP is essentially your minute ventilation. So that's what's going to be driving pressure through the whole process is your IPAP. That's your minute ventilation. And we know that we talked about minute ventilation is the key culprit that's causing the oxygenation problem. So an IPAP of 10 would be a great starting point for a pediatric patient. And then the EPAP. The EPAP is basically the PEEP, or what's holding those alveoli open. But it's also a pressure gradient that we're setting. So if we have an IPAP of 10 and an EPAP of 2, we have a larger pressure gradient. And let's compare that to, let's say, a patient that was suffering from hypoxia secondary to maybe pulmonary edema. In that situation, we would have an IPAP of 10, but we may have an EPAP of 6. And the reason why is because we have an oxygenation problem. We have to keep those alveoli open throughout that whole face a little bit more aggressively. And so that gradient, 10 versus 6, is going to be closer together. And so that's the standard treatment modality for a patient that was hypoxic. But when you're talking about a patient that's suffering from ventilatory failure as a primary insult, you would want that gradient to be farther apart. So that's where we would go an IPAP of 10 and an EPAP of 2. So they have a lower pressure to exhale over, and that's going to help them optimize exhalation. It's going to reduce the auto PEEP and the air trapping, and that's exactly what we want to do because we know that's the big problem. Our patient is becoming so fatigued, their muscles, their chest wall muscles are so fatigued by trying to overcome these high airway pressures, this poor chest wall compliance, just to get all this air out, and they become very sick. So that's the main goal in treating these patients. We've started all the pharmacological interventions. Now we're going to optimize all that with good BiPAP management. And so that's the new mindset in treating these asthma patients, is going to BiPAP very early. You can do inline nebs with BiPAP. You can put an inline neb right underneath the mask and continue with nebs throughout that whole process. And your patients will do very well. The ketamine is a big thing here. Remember, ketamine optimizes bronchodilation, has some analgesic effects. It helps with that sedation aspect to keep them calm, lowers that respiratory rate down. And by doing all this in conjunction, you're going to optimize the exhalation process, and they're going to start improving. If all that doesn't work and you're still seeing that your patient's struggling and he's still tired, then we can go with another medication. And kind of a last line medication that we see around the country is mag sulfate. And we know that mag sulfate is your primary medication for preeclampsia, eclampsia, patients that are in preterm labor and things like that. But when we look at mag sulfate in larger doses, mag sulfate has great beta-2 effects. It's a beta-2 agonist. So large doses, it causes smooth muscle relaxation of those bronchioles. So we would start with some mag sulfate, and we could go 50 milligrams per kilogram IV over 20 minutes, and you can start this in a drip and infuse that in, and that's going to possibly help this patient. The other thing we want to think about is the patient did get some PO steroids, and oftentimes in the pre-hospital setting, we forget about long-term, and I think that's the big difference in looking at your patient's clinical course from an acute standpoint versus a critical care standpoint. And as a flight nurse or flight paramedic, it's the expectation around the country that you look at things from a clinical course aspect, from a care plan aspect, and think about an hour, 2 hours after you drop the patient off. Can you do something now that's going to affect them in a positive way 2 hours down the road? So corticosteroids, as small as that really is, giving Solumedrol 2 milligrams per kilogram to this patient would be a great thing, could help them in the long run. And then the other thing to consider is antibiotics. Again, we talked about ruling out an infectious process. We talked about looking at the white blood cells, looking at the leukocytes, looking at the bands, seeing if we have immature white cells, and identifying on the chest x-ray, confirming if you have some type of infectious process, right? So we're afebrile. Our chest x-ray showed that we had no possible pneumonia. We had a chest x-ray that showed hyperinflated lungs, a very flattened diaphragm. So in this patient, I wouldn't give antibiotics. If I were suspecting that there was some type of an infectious process, Rocephin would be a great broad-spectrum medication that would, hit gram-negative and gram-positive bacteria. So I would continue with this treatment modality. I would continue being aggressive with my pharmacological interventions. I really believe that being aggressive with your ketamine in small aliquots, being aggressive with your BiPAP, understanding that pressure gradient, oftentimes you can turn these patients around. If you can't turn this patient around, you've tried all these things, you've been aggressive with all your pharmacological intervention, and you have to intubate these patients, I think it's important that we talk briefly about the ventilator aspect here. So if we had to RSI them really quickly, we would go through and we would use fentanyl as our pain induction sedative style medication. Remember, 3 mics per kilogram is going to be a great starting dose. Again, confirm that with your local protocols, but in this area, that's our induction dose, fentanyl. We start with fentanyl, 3 mics per kilo. That blunts that sympathetic response that we get with intubation with the laryngeal stimulation. I would then go ketamine, 2 milligrams per kilogram. That's, again, going to optimize bronchodilation. It's going to help with the analgesia as well. And then I'm going to go with succinylcholine and induct my patient with paralysis that way. So let's just imagine we've intubated our patient. Remember, use the largest ET tube that you can get in this patient. So confirm that with your Broslow tape. Confirm it with, you can match it up to their pinky. Remember the formula, 16 plus the age divided by 4, and that's going to give you a great ET tube size. So we've intubated our patient, and now we need to put them on the mechanical ventilator. The big thing to understand is we have different modes. We have assist control and SIMV, and one of my big things that I love learning about is ventilator management and ventilator strategies. And I've talked to a lot of respiratory therapists. I've talked to physicians around the country, and the big stance right now is using SIMV. And the reason why is that they've identified that our muscles, if it's put on a mode like assist control, and we're not allowed to take spontaneous breaths, our muscles atrophy very, very quickly. And they've done studies where they atrophy within 24 hours. We know that that's a big part of an asthma patient. When we put them on the ventilator, their muscles atrophy and they're not allowed to fire. And so it's really hard to get these patients off the ventilator. That's what the whole point of not intubating these patients is that, and then some type of a possible pseudomonal infection or pneumonia that's hospital induced. All right, and that increases mortality and morbidity right there. So if we can keep them off the ventilator, that's kind of the thought process. So my mode of ventilation for this patient is going to be SIMV. I'm going to still keep their sedation and their pain management at a level where they can take some spontaneous respirations. I don't want to increase their workload of breathing too much to where they have continued muscle fatigue, but I still want to have those muscles firing. So SIMV is going to allow me to do that. I'm going to set a trigger of about 3 to 4. Remember, in an aircraft like a BK-117 that has a lot of vibration, you would want to set that trigger a little bit higher so that the ventilator doesn't trigger off the vibration of the aircraft. And then we have to look at the protective mechanism here. What's going to protect the patient from having more auto PEEP and more air trapping? Well, the protective aspect, the obstructive lung approach, is having a lower respiratory rate. And so we would want to bring his respiratory rate down to a level that would be physiologic. And I would say bring that rate down between 16 and 20, keep it in that range. And then the second thing we want to do is we want to continue with optimizing the exhalation phase. And we do that in these patients by an ID ratio. Your IDE ratio for a standard pediatric is about 1 to 3, right? Because they have a higher rate physiologically anyway. So in this patient, I would want to extend that ID ratio out to 1 to 4, 1 to 5, maybe 1 to 6 based on how they're doing. And you can gauge this easily by having your end-tidal CO2 on and watching that trending that based on your blood gas. The last thing that you would think about is, do we want this on volume or do you want this on pressure? And if you've heard my other podcasts, I'm a big advocate for using pressure control ventilation. And I know that there's a little bit more that goes into using that mode of ventilation, but I'm convinced based on my clinical practice and what I've seen as far as treating my patients that it really does benefit our patients. Remember that pressure control ventilation is for those weak, sick baby lungs. And if we don't use pressure control ventilation, we do have the risk of possible barotrauma and hyperinflating those lungs past a point that they can handle. We know that that can cause increased plateau pressures and increased peak inspiratory pressures. We already have high PIP pressures with an asthma patient. So why would we want to maybe cause further damage? So for me, I'm going to use pressure control ventilation. I'm going to set a pressure based on my PIP and my current PEEP, and I'm going to watch that based on my exhale tidal volume, and I'm going to try to maintain an exhale tidal volume that's physiologic for this patient. So I believe this patient's about 20 kilos. At 6 mils per kilogram, I would want my tidal volume to be in the 100 to 120 mil range. And so based on pressure control ventilation, I would want my exhale tidal volume to be in that exact range. And this is another great tool to monitor his chest wall compliance, because if you start seeing that exhale tidal volume increasing, what that's telling you is that you're improving his chest wall compliance, that he's able to take larger tidal volume breaths, that his lung is able to inflate to a higher pressure, or I should say his lung is able to inflate to a higher tidal volume based on that set pressure. So that's a good thing. That means that all the pharmacological intervention that you're doing, the ventilator strategy that you're implementing, is doing a good thing. On the contrary, though, you could also see him deteriorate based on just that exhale tidal volume. So if his chest wall compliance starts decreasing, that exhale tidal volume will start decreasing accordingly. And so you can see that and trend that. So some things to consider. If you have a pediatric patient or even an adult patient that starts decompensating on the ventilator based on his disease process, 99% of the time, it's always going to be because he has too much stored air, too much auto PEEP and air trapping. And so the treatment is going to be just taking him off the ventilator, maybe pushing gently on his chest and helping him exhale, or letting him just spontaneously exhale out all that volume. And so oftentimes you'll see patients that will start decompensating, that exhale tidal volume will start dropping and dropping. That'll essentially start causing a cardiac tamponade, tension pneumothorax type effect where it's pressing against the vessels. So you're going to start seeing the heart rate drop, the oxygenation status drop. And again, the number one treatment, it's not a pneumothorax, it's not a displaced ET tube, it's too much volume trapped in the chest, and just take them off the ventilator and just let them blow off the excess air that's trapped in those lungs and the alveoli. So that's the main strategy there. The protective mechanism, again, is the respiratory rate and the ID ratio, allowing them to blow off the CO2. So when we look at this disease process, that's essentially it. We need to continue with our pharmacological intervention, be aggressive early. Don't forget about being aggressive with your epinephrine and your terbutaline if you have that in your arsenal, if you have that in your toolbox. But epinephrine is something that we use in anaphylaxis. It's the same, essentially the same disease process or manifestation and attacking those epithelial tissues. So it'll work very, very well. And go through your different medications. Don't forget to use your BiPAP. BiPAP is going to be your number one go-to adjunct early on in these patients, and it could turn these patients around. Remember, we don't want to intubate these patients if at all possible. If that means that you're watching them really, really suck air, if they look fatigued, they look, just let it ride, and that's again the mindset of the physicians, the intensivists around the country in treating these patients. And that goes the same for your adult patients. It's the same kind of process. So that's all I have for this presentation. If you have any questions, please email me at eric@flightbridgeed.com. Remember, you can always refer back to other podcasts that kind of hit on the different aspects that I've talked about. There's podcasts on oxygenation and ventilation. There's podcasts on gas laws, and I know gas laws may be really boring to people, but there's certain gas laws, especially Henry's Law, that really affect diffusion of CO2 and oxygen. So that's a really important one. And then I've got a 3-part series on RSI. I've got a 3-part series on ventilator management strategies that go really deep into the injury approach and the obstructive approach, and all that stuff will kind of help you understand this process. Remember, we have our book that's published. We're selling a lot of them. We want to thank everybody if you're out there and you've purchased one. We want to hear your feedback. You can purchase those on our website, and that's going to give you a 206 full-color pages of critical care review related to the CFR and FPC. We've got another book that's about to be released called the FAST Exam Prep Book, and that's going to be a full encompassing book with very difficult questions that will help you prepare for these exams. And then remember, we have our ventilator management a HIMSS perspective book set to be released in February of 2014. So again, thank you from all of us at FlightBridgeED for joining us, and we'll talk to you soon. We want to thank you for following FlightBridgeED.